Anna-Maria is our next speaker. Anna-Maria Lahesmaa-Korpinen is passionate about using data to answer questions in biomedicine. And she has a background in academia. She has worked in molecular biology group and bioinformatics group at University of Helsinki and also Finnish Institute for Health and Welfare. She later moved to the private sector where she is now, but she still stayed close to medical and health data. She worked previously at Terveystalo and Heinstop Performance, but now she's at Mehiläinen. And she is going to talk about data science for health and well-being today. Anna-Maria, the floor is yours.
Thanks. Can you hear me okay?
Yeah, perfect. Yeah.
Perfect. So thank you, Seppinud, for inviting me already over a year ago, but here we are today virtually. This is great. It's great to be here to have a chance to talk to you guys today. My topic is a bit changed, so I'll be talking about data science for smart digital healthcare. And I'll describe some of the work I've been initiating since recently starting at Mehiläinen. So Seppinud introduced me, but a little bit about myself. I'm a data scientist at Mehiläinen for almost 2 months now, which I'll get to more in a second. I've been working in the intersection of healthcare, biomedicine, and computer science for over 15 years. In academia with my PhD in computational systems biology, and then pharmacoepidemiology at the Finnish Institute for Health and Welfare. And then now in the private sector for almost 5 years in healthcare, and then at Terveystalo as a data scientist and data analytics lead at Heinstop Performance, where that focuses on coaching and well-being for individuals and organizations. So if you're interested, feel free to connect on LinkedIn, although I'm not super active there. If you search for my name, it's relatively unique. So Mehiläinen. Mehiläinen is a leading Finnish healthcare provider and has a 111-year-old history here in Finland. It has customers including corporations, insurance providers, public sector, and of course, private individuals. And as I will soon talk about more, Mehiläinen is a pioneer in the development and adoption of digital healthcare solutions, which is why it's especially interesting from a data perspective. The 3 main business areas at Mehiläinen are the private healthcare services, so physician services, diagnostics, operations, dental care, and working life services, so occupational health. Then there's the public healthcare services, so health centers with customers' freedom of choice, outsourced services, public dental care, emergency care services, and home care services. And the third area is social care services, including residential care services for the elderly and the disabled, mental health care, mental health rehabilitation services, and child welfare services. Mehiläinen has roughly 1.3 million customers annually in Finland, 540 locations here, and over 22,000 employees and private practitioners. And as a new flavor in November of 2020, so about half a year ago, Mehiläinen established a new company called Be Healthy to take our digital tools and platforms abroad and to focus on our international growth. And the growth strategy has 3 areas. So first, the expansion into the core markets abroad, as seen here in green, with expansion with actual purchases of clinics in those countries. And in these cases, we'll use the Mehiläinen know-how both in managing physical clinics as well as developing the digital services on site. Then in purple, you can see the sites where we've sold our digital platform as a software as a service provider. And this will enable a fast forwarding of the digital leap in those countries and those clinics. The third area for Be Healthy and our international journey are these chronic care pathways that are under development. These will serve both external customers and our current ones, and their focus is, for example, on developing care models for example, chronically diabetic patients. So overall, both in Finland and now growingly internationally, Mehiläinen has good capability when it comes to data, and we have good, clear aims to continually improve our services using data. And data quality and good quality healthcare with reliable data is something we're passionate about. And we have published our data related to quality in our Laatukenno, which is currently unfortunately only in Finnish. But let's see, we have published our data, for example, our customer satisfaction NPS values, availability, how quickly you can book an appointment or how long lab results take, safety, elderly care services safety, reported patient injuries, safety in surgeries, not prescribing unnecessary medicines that might use as narcotics, effectiveness, so for our treatments, for example, in diabetes care and dental care, and finally, our satisfaction of our own employees. And these metrics are constantly being updated, and we're developing new metrics as we speak to measure new relevant things. So go check this page out if you're interested, and feel free to contact me if you're interested in these. So even before the COVID pandemic, Mehiläinen was a pioneer in digital healthcare solutions. But as we all know, when the pandemic hit, it increased this digital demand immediately. And in Finland, Mehiläinen increased the capacity of our digital clinic and expanded these remote appointments that we have to cover the services of all our professionals. The number of users registered in the Oma Mehiläinen service, which is our platform name, exceeded 1 million in September, with visitor numbers multiplying from the previous years. And a total number of registered users currently is about 1.3 million. And in 2020, overall, the digital clinic became the largest unit of Mehiläinen instead of a physical location. And we've seen that the digital clinic hasn't cannibalized physical visits, but actually has fueled growth in the physical units as well. So what am I talking about when I talk about the digital platform? It includes tools for the professionals and administration side, but I will be focusing on the data collected from our digital tools for private individuals, and especially the digital clinic we have there. So through the digital clinic that you can access through your mobile phone or your web browser, an individual can contact a physician 24/7 and get quick access to treatment without making an appointment. So these remote visits can be used to treat symptoms and diseases that don't require a physical examination. Obviously, not all things can be handled virtually, but by visiting the digital clinic, you can also see what kinds of possibilities there are. So how the remote appointment starts: you start the window in the app, and you select your main symptom category. So for example, here this client Yaba has selected these symptoms for respiratory infection, and then is asked more questions about their current symptoms. So here you're asked about shortness of breath, fever, other symptoms, any medications that you're currently on, any allergy medications and such. And at the end, it's possible to there's a free text place for any other descriptions about the current situation. This symptom assessment helps the physician work and improves patient safety. So for the user, it feels like a natural conversation they would have with a physician. If they would go to a physical location, these questions are the same questions the physician would ask them, but here they're delivered right in an orderly fashion, and then there's no worry that the doctor would forget to ask some of these questions. And users are quite used to using these kinds of chat type interfaces. Then for the doctor can see the data summarized as an anamnesis, and then especially important findings are highlighted. So for example, here, a high fever or difficulty in breathing, these can then be highlighted so that the doctor gets the information as quickly as possible. And you can imagine all the possibilities related to this kind of basic data visualizations in an anamnesis. There's additionally, of course, an administrative interface to create or modify symptom assessments. So if there's something not available, these can also be created. Then I will move on to the actual data, what it looks like that we're currently getting. Here's the virtual clinic number of visits per month that I'm working with currently. So the visits starting from the beginning of 2020 up to the end of May, which is a total of 730 visits. And here you can see the significant peak here in March. And down here is sort of the level where it was before this nice, lovely pandemic we're in right now. It slows down a bit during the summer, and then now seems to have leveled off at somewhere around 40,000 visits per month. Yes. And then for the symptom assessment usage, so not all visits to the digital clinic use the symptom assessment overall. And currently the data looks that it's sort of leveled off here, that about 60% of the, so the gray is the visits with the symptom assessment. So roughly 60% of users who start the digital virtual visit use the symptom assessment dialogue. And what does that mean? So about 40%, there are the cases where you don't use the symptom assessment are, for example, when you're contacting customer service directly to reserve an appointment, or when you're renewing a prescription. But there's roughly 315 visits, 15,000 visits, of which have information about the symptom assessments. The majority of these symptom assessments are related to symptoms of symptoms of respiratory infection, so 65%, and that's a big chunk of the data. The other major symptoms that have high numbers of visit data are eye symptoms, women's urinary tract infection, and musculoskeletal symptoms. And these even only have 4 and 3% of cases currently. 25% of the data is then all the other symptoms that are reported. So rashes, diarrheas, headache, allergies, sore throat, and an other category, or if you don't find your symptom in the list of symptoms. And each of these has roughly 1% of the data mass that's been collected. And actually, I think the first thing probably for anyone working with data is to think about what kinds of diagnoses are these people getting. And actually, a colleague has previously developed a diagnosis prediction model with these symptom assessment data. And his findings were that due to the highly skewed data towards the respiratory infections, these respiratory infections were pretty well predicted. However, other diagnoses weren't so well predicted. And this is definitely something we're going to be looking into more. And since these initial runs were done about roughly a year ago, there's a lot more. There's a larger data set now available. So this is something that we will be looking into in the future. And right now, what we're hoping to do next is, instead of looking at diagnoses for these based on these symptom assessments, is to look for, start with a bit of a simpler model. And we will be starting a pilot where our goal is to develop rules for how to direct a customer directly to a professional that can treat them with the highest probability, or to find the best fit for a physician. And why is this relevant? So what we want to do is to have the smartest and fastest way of treating a client. So currently the times of the visit, we have an 8-minute median wait time for the first message. This obviously depends also on the day and time of the visit. So Monday mornings are especially busy. And then the other part is the majority of customers are cared by one professional during their virtual visit, and 12% are moved forward to one or more other professionals, for example, directed to customer services to reserve a time because it's something you need to take care of at a physical location. So this is the actual process of the virtual visit is what we want to start developing. And this was initiated because we have already 2 processes where we direct the patient to a specific type of practitioner. And we've seen promising results with these. So we have a specific symptom assessment for musculoskeletal issues, where the clients are directed directly to an occupational physiotherapist, so they can get assistance more immediately related to their musculoskeletal issues. And then we also have a worry chat where the customer is directed to an occupational health nurse trained for mental health. And both these changes in processes provide the customer with help faster, and these types of tools we want to develop for our other symptoms. This is sort of the data, the current status of this project, as I've recently just started, and a lot of work in progress. But the future work, and I'd be happy to discuss these ideas with the audience. The idea is to develop our data model to enable prediction of the type of physician to the patient. Is to develop the data model to enable the prediction of the type of physician that the patient should be sent to based on their symptom assessment results. And this will include data related to revisits and possible visits to physical locations. Then with these predictions, we can build up the physician capacity in the digital clinic to respond to the demands needed. So there needs to be actually those physicians in those specialties as digital clinic doctors. And like I previously mentioned, we will be doing this in an upcoming pilot. And then during the pilot, we can measure various metrics related to waiting times and conversation times and revisits, numbers of revisits. And we can look at how these metrics change and whether these predictions and physician assignments improved our metrics. So there's a lot of work still to do, and I'm sorry I wasn't able to present any results yet. But I have great colleagues that I'm working with in the team, and I want to thank all of them for all the help getting started with this work. So that's it for my presentation. And I'd be happy to take any questions and comments that come into mind.
Thank you so much. Okay, kiitos paljon for your talk. There is a question. Could you comment on how the patient data is stored?
Can you say that again?
Could you comment on how the patient data is stored?
Yeah, so it's stored in the cloud and in our own servers. So we have both on-prem and cloud resources for the data. And because the medical healthcare area is so highly regulated, there are quite a few sort of there are things that need to be considered when doing both data science, actual algorithms and analytics with the data, and also exactly that where the data is stored and how it's moved around is quite stringently regulated.
Okay, thank you. There is a question. I know you could open your mic and talk. Yeah, I think you should be all over. Yeah.
Okay, now I should be on mute.
Yeah.
Okay, awesome. Thanks a lot. So I was just wondering, you were talking about the big class imbalance when you're doing that symptom classification. I was wondering if there is like some issues with the traditional class imbalance techniques, why you cannot use them or they don't work in this case, such as synthetic oversampling or anything like that. You kind of comment on the class imbalance and how you could work with that.
Yeah. So this was actually this was work done by a colleague, so I'm not I'm not the best to answer to all the details, but I think it was sort of a test run with a more classical classifier, and I'm sure that a lot of things could be improved just using somewhat more advanced techniques or different types of data balancing strategies. And
okay, thank you. Yeah, I was curious if there's like something like particular about the kind of like healthcare data where these kind of methods wouldn't work, such as like synthetic oversampling.
Well, I don't think it's the case. I think part of it is also that the how traditionally healthcare data is stored is not it's not initially very usable for analytics. So there is a lot of data wrangling required to get the data into formats. For example, I mean, so the patient records are specifically designed to be patient records and not necessarily to be used for analytics. So for example, in a lot of systems, the diagnosis may have especially before these days, maybe not so much, but just a free text field where without any checks. So for example, just getting the right format of a diagnosis can be a lot of challenging work. So a lot of the data work that I've been involved in, actually all through my work in these biomedical and healthcare scenarios, are related to actually getting the data into nicely structured and format, so it's possible to do the actual analytics.
Sure. Okay, thanks a lot.
Thank you, Aina, for the question. If there's no other question, I have one. How systematically you're, I mean, again, related to the data, are recording the data, and is it like how much data you have on the patient's background and history and their diagnosis, and are you planning to do that for doing any diagnostics, smart diagnostics in future?
Yeah, so I mean, I think the I mean, healthcare is so reactive still these days. So you come to the doctor when you're sick. So the type of data that that's in patient records is data about patients when they're not feeling so good. So in that sense, the data is already sort of biased towards that. But we do have, obviously it depends how long a patient has visited Mehiläinen facilities. And obviously in Finland, you may go to a private healthcare, you may go to public visits. So our data sources are only the ones that includes visits to Mehiläinen. But there we do have access to their previous diagnoses. And I mean, obviously part of the medical, like part of treating a patient is understanding their previous diagnoses and underlying conditions that need to be recorded in the database. So things like that are quite relevant then to actually creating predictive models.
Okay, thank you very much, and thank you for your talk, and we are in time.